Okay, I think we are time. I welcome everyone to the next installment of the APSC Cloud Forum of Cardiovascular Disease series. Today's topic is themed as a paradigm shift for pharmacological as well as non-pharmacological treatment of acute and chronic heart failure, the Asia Pacific point of view. A date stamp today is the 17th November 2021, 12 p.m. Singapore, Taiwan time. I'd just like to give a quick preamble to today's session. There are more and more really trials coming out, pushing forward guidelines regarding acute and chronic heart failure management, where Paradigm, Paragon, DAPA-HF, Emperor Reduce, as well as Preserve. And this have demonstrated clear-cut benefit for both the ARNI class of drugs as well as SGLT2 inhibitors in the acute and chronic pharmacological management of heart failure, with, frankly speaking, reduced to mildly reduced to even a subset of normal EF heart failure patients in the HFpEF group. The CASTLE, PEF, AF, CRT, COAP, and mitral FR demonstrate both the decision-making points for radio frequency catheter ablation for AF with or without CRT therapy in AF complicating HFrEF patient, as well as a mitral clip H-to-H repair therapy for severe functional mitral regurgitation complicating the subgroup of patient with HFrEF. So pharmacological combined with non-pharmacological device approaches are evolving as a core components acute as well as chronic progressive heart failure management. And today we have great speakers to tease out these trials as well as give us further insights. So my name is Jack, the immediate past president for the APSC, your chair for session 1. And I'm very happy to have my chairperson 2, Professor Chi-Min Lee, Professor of Medicine at NTUH Taipei, Taiwan, as the chair and closing chair for this session. Our first speaker is a good friend, Dr. Park Jin-ju from South Korea. He's going to speak to us on the piece on ARNI, replacing ACE inhibitor RAS therapy as the first-line therapy for acute as well as chronic heart failure in HFrEF from the ACC ESC guideline to the real world. This will be followed by the renowned Dr. Rong Roach from Thailand. As you can see, he's a president at the current ASEAN Federation of Cardiology, president at the Thai Heart Association of Thailand, president at the Heart Failure Council of Thailand, as well as the Thai Society of Cardiovascular Imaging. He's going to speak to us on SGLT2 inhibitors on the front line for HFrEF, HFpEF management with or without diabetes, drawing on DAPA-HF, Emperor Reduce, Preserve to the real world. The next speaker is Dr. Chi-Chia Yo, assistant professor from NTUH Taiwan, Taipei. She's going to then switch tracks into AF junctional ablation plus CRT versus catheter ablation rhythm control in HFrEF complicating persistent AF. So we're going to switch track into AF complicating heart failure, drawing from the CASTLE, APEF, CRT trials to the real world. The finishing lecture will be given by my good friend, Professor Yu Si Hui, Senior Consultant Cardiologist at the National Heart Center, Singapore. She's going to speak then as a closing lecture on functional mitral regurgitation and its outcome in HFrEF and its implication for device therapy in H-to-H repair in mitral clip. So without further ado, I would like to give a quick disclaimer. The content is copyrighted by the APSC. The views expressed here are those of the faculty members and do not necessarily represent those of the APSC. This content is currently made live stream through the APSC Cloud, APSC Facebook, as well as YouTube pages. And we'll draw on the first lecture now from Professor Park Jin-ju on the ARNI class of drugs. Jin-ju, please.
Thank you very much for the great introduction. I'm going to talk about ARNI in heart failure. I'm Jin-ju Park. I'm from Seoul National University. First, I'm going to talk a little bit about chronic heart failure, ARNI, the famous Paradigm HF study. As you know, heart failure had very bad prognosis. The red line is heart failure. It is worse prognosis than most cancers except for lung cancer. And I'm pretty sure if you have a heart failure patient for the acute heart failure admission, The remaining survival is about 2.5 years. After 3 admissions, the remaining survival is less than 1 year. And that's the reason why you have patient with acute heart failure admission less than 3 or 4 times, because all of them die. But fortunately, there are currently 8 classes of drug in HFrEF, which improve the survival, starting with the ACE inhibitors, beta blockers, etc. And the 5th drug is sacubitril/valsartan. So when you look at the clinical study results here, beginning with the SOLVE trial in 1991 with enalapril, then beta blockers, bisoprol, MRA, and ivabradine and sacubitril/valsartan, etc. These drugs are targeting neurohumoral activation. The 3 other drugs, SGLT2 inhibitor is a cardiometabolic drug, very secret, and omecamtiv work on the cellular level. So we always talked about neurohumoral activation or the inhibition in heart failure, but now we are moving from that term to the neurohumoral modulation. So you have a sympathetic nervous system, a RAS system, natriuretic peptide system, and kinin system. If you want to block the sympathetic nervous system, you use beta blockers. For RAS inhibition, you have a RAS inhibitor such as ACE inhibitor, ARB, and MRA. As for the natriuretic peptide, we have an enhancer. We enhance natriuretic peptide level by inhibit the neprilysin. So I personally say that natriuretic peptide is the natural antagonist of the RAS system because it does exactly opposite of the RAS system. So if you have an angiotensin II here, it exerts via angiotensin receptor, sodium water retention in kidney, but the natriuretic peptide, as the name says, causes natriuresis. It also dilates the vessel, inhibits hypertrophy and fibrosis, and lowers the sympathetic outflow. So it does all the good things and in the neurohumoral pathway. When you have RNA, sacubitril/valsartan, the sacubitril will be metabolized to LBQ657, which inhibits neprilysin. And this neprilysin is necessary for degradation of AMPPM CMP. And by inhibiting this neprilysin, you have enhanced function of the natriuretic peptides here with all the good outcomes. And you have a valsartan resistant RAS blocker, and it's a very typical and classic ARB, and that blocks the RAS pathway. So we have a dual action with the sacubitril/valsartan. In the PARADIGM-HF study, which include ejection fraction less than 40% heart failure with reduced EF patient, more than 8,000 patients were enrolled. They were randomized either to RNA as the 696 or enalapril, and the primary endpoint was the composite of CV death or heart hospitalization. The study has a run-in period, and after this run-in period, the patients were randomized to the 2 groups. And the primary endpoint, the CV death or heart failure hospitalization, could be reduced by 20%. If you look at the curve, there's a very early separation of the curves. The p-value has 0.0000002, so 770, and number needed to treat was 21. This highly significant p-value suggests that this study has a power of 2 or 3 randomized clinical trials. When you're looking at the cardiovascular death, there's a 20% risk reduction with a very high significant p-value, 21% risk reduction for heart failure hospitalization, and 16% risk reduction for all-cause mortality. So number needed to treat in PARADIGM-HF study was 21%. And it was a study that compared with enalapril, an active comparator. In SOLVE study, enalapril compared to placebo had an NNT of 23, relative risk reduction by 16%. So when you compare the studies here below, they are comparing against the placebo, whereas the Paradigm HF, you have an active comparator. When you perform a putative placebo comparison, sacubitril/valsartan may reduce the risk by around 50%, much stronger. What about these secondary outcomes? The KCCQ score is better with the sacubitril/valsartan group compared to the enalapril group. The safety issue was very important because it was the first class drug that was tested in human, and a patient with the sacubitril/valsartan had a more symptomatic hypertension, but they had lower increase in creatinine level, and most importantly, the cough, they had less cough, and the angioedema did not differ between both groups. Sacubitril/valsartan can prolong survival about 2 years. If you start the drug at the age of 55, you have a survival gain of 2.1 year. When you start the drug at age of 65, you have a survival gain of 1.6 years. So in 2012, it does not mention anything about sacubitril/valsartan. The Paradigm HF study came out in 2014, and after 2 years, the ESC guideline includes RNE, sacubitril/valsartan in the guideline. The very recent guideline from ESC suggests to use asymptotic ARB, beta blocker, MRA, and SJ2 inhibitor, which is all called the Fantastic Four. And when you're looking at the guideline, these four Fantastic Four are recommended, but ARB is recommended if the patient is ACE inhibitor or RNA intolerant. The reason is that ARB has failed to show survival benefit, whereas these four drug classes have improved survival in HFrEF patients. I'll show you a case of a patient. He's a 40-year-old male patient who came with dyspnea. He has a 10-year history of a hypertension, congestive heart failure with NYHA function class 2 dyspnea. 1 month ago, he has dyspnea aggravated to NIH function class 3 or 4. He was on carvedilol and valsartan, and his blood pressure was 136/80. At the first medical contact, his chest X-ray shows a large heart cardiomegaly here. ECG shows a very large QRS complex with a T-wave involution in the lateral leads. So he receives carvedilol 12.5 milligram twice a day, ivabradine 5 milligram, sacubitril/valsartan 100 milligram twice a day, and furosemide 40 milligram twice a day. And after 6 months of after medical therapy, his heart size decreased in the chest X-ray, and the large QRS complex in the initial ECG decreased in size here. Echo at admission at the first medical contact, the LV end-diastolic diameter was 64 millimeter, ejection fraction of 23, and after 6 months, the heart decreased by 10 millimeter, ejection fraction increased from 23 to 51%. The next question is that whether we can use the sacubitril/valsartan in acute heart failure. You may say, why not? Because it's safe in chronic heart failure, but there are some things we have to consider. So Paradigm HF study involved patients who are stable chronic heart failure patient, and Pioneer study is the first study which addressed the question in acute heart failure. The Paradigm HF study, as I told before, included chronic heart failure patient. The patient needs to be on stable guideline-directed medical therapy for heart failure for at least 4 weeks, and patients with acute decompensated heart failure were excluded. When you're looking at the study design of the Paradigm HF, it has 2 periods. The one is the running period. The second was the treatment period. At the screening, there were more than 10,500 patients who were screened and entered the running phase, and they were exposed to enalapril, sacubitril valsartan for 4 weeks. And if everything was okay, then the patient was randomized. And in this time, more than 200 or 20% of the patient were excluded from the paradigm HF study. So the safety issue is not clear whether you can use it from the very beginning. So Pioneer HF study included a hospitalization patient with an acute compensated heart failure and reduced ejection fraction. If they're stable, they were randomized either to sacubitril valsartan or enalapril for 8 weeks. The inclusion criteria were acute heart failure, ejection fraction less or equal to 40%, increase is NT-proBNP level, and they should be stabilized. That means they do not receive any inotropes, no IV vasodilators, no increase in IV diuretics, and blood pressure greater than 100. So over 440 patients were randomized to sacubitril valsartan, and 441 patients were randomized to enalapril group. The median ejection fraction of 24-25. Systolic blood pressure was 118 here. The primary endpoint was the time average, the proportional change of NT-proBNP level from the baseline. If you look at the enalapril, there is a very good decrease of NT-proBNP level, but in the sacubitril valsartan level, the NT-proBNP decreased about 45% at 1 week, and at the end of study, after 2 weeks, greater than 50%. So there is a 30% risk reduction with the sacubitril valsartan compared to enalapril. Safety is the big issue here because we wanted to know whether the sacubitril valsartan is safe in acute heart failure patient. Worsening renal function, 13.6 versus 14.7, no difference. The same is for hyperkalemia, symptomatic hypertension, and angioedema events. There were additional clinical endpoints. The serious composite of the endpoints were 9.3 in sacubitril valsartan and enalapril 16.8%, so that the hazard is 0.54, which was mainly driven by the reduction in deaths and rehospitalization rate. When you look at the hazard ratio, they are pretty the same. So when you plot the outcome here using a Kaplan-Meier survival curves, sacubitril valsartan patient had less event, a reduction of the risk by 46%, number needed to treat is 13%, and most important is very early separation of the curves. There's another open label extension trial. The patients who were in the enalapril arms, they were switched to sacubitril valsartan and were followed. Interestingly, the curve between the two groups were parallel to each other. That means that when you have a loss in this treatment period, cannot be caught up or cannot be made up during the follow-up. That means you should use the drug as soon as possible to have the early benefit. The conclusion of the Pioneer HF study was that the primary endpoint, the great reduction of NT-proBNP level, and it is safe because the rate of worsening renal function, hyperkalemia, symptomatic hypertension, and angioedema did not differ between the two groups. So when you're looking at the drugs in acute heart failure, actually all failed until now. Nesiritide or ularitide, the recombinant BNP analog failed. Serelexin also failed in the RELAX-HF study. The two drugs which were promising is the SJ2 inhibitor in the SOLOIST AHF trial and sacubitril valsartan in the Pioneer HF trials. I'm going to talk a little bit about this drug in special perspective, let's say. The first issue is reverse remodeling. So if you have a heart failure patient, there is an initial injury to the myocyte or the cardiac myocyte and the matrix, and they will lead to systemic neurohumoral overactivation that leads to structural changes and adaptive remodeling and progressive worsening of the LV function. The cardiac remodeling is associated with the morbidity and mortality. So if you have a large heart, the patient has worse prognosis. The hemodynamic alteration, which is the muscle congestion due to water and solid and water retention, will lead to symptoms. The best drug which will improve the hemodynamic congestion is the diuretics. It leads to immediate improvement of the symptom, but as you know, Lasix does not improve the survival. Beta blocker, RAS inhibitor, they do cause a reverse remodeling. They improve the survival, but as you know, if you give this drug, the symptoms of a heart failure patient will not be better immediately. So we have two pathways, and if you want to improve the outcome of the patient, you need to target the remodeling of the heart. In the PROVE-HF study, there was this study investigated the association between NT-proBNP change and cardiac remodeling, and include a half-red patient, about 800, being ejection fraction was 29%, 65 years old, and it was single-arm study, so that all patients received sacubitril/valsartan 200 milligrams twice a day. And if you look at the patient, as I told, they were 65 years old. Only very few Asians were included in the study. They were well treated, beta blocker 95%, ACE in there, ARB 75%, MRS 35%. So when you look at the change in the NT-proBNP level, there's a very abrupt decrease at the very beginning. After 2 weeks, the NT-proBNP decreased from 770 something to 550 something. After 1 year, it will decrease to around 400. So there's about a 45% decrease in NT-proBNP level during the study follow-up. And on the x-axis, you have a change in the NT-proBNP level. The y-axis various variables for cardiac remodeling. And if you have a great decrease in NT-proBNP level, ejection fraction increase here on the very left, about 20%. LV end-diastolic volume index, LA volume index, systolic volume, they all decrease here with the decrease of NT-proBNP level during the follow-up. When you're looking at the EF at the baseline, the EF was 28%, and after 12 months, it increased to it's increased by 9%. The LV end-diastolic volume index decreased by 12, and LV end systolic volume index decreased by 50 milliliter per square meter by the surface. The LA volume index decreased by 7 milliliter per square meter. So in the PROVE-HF study, it shows that the largest reduction in NT-proBNP level and LV end-systolic volume by 6 months, this patient has the lowest rate of death or heart failure hospitalization. So the cardiac reverse remodeling is very, very important, and it provides a mechanical explanation for the effect of sacubitril/valsartan in half-red patient. So what about the dosing in the real world? As you know, if you prescribe sacubitril/valsartan, you will experience that many patients will have a hypertension. So what about the dose in the RCT or in RCT? In PARADIGM-HF study, all patients were up-titrated to the target dose. And in the sacubitril/valsartan arm, about 40% had dose reduction during the follow-up. And about 37% of this patient returned to the target dose. That means the 2/3 had their were on the lower dose than target. In the IMPROVE study, about 65% has a 200 milligram twice a day, the target dose. That means 35% had a dose less than the target during the follow-up. We looked at the data in Korea, and there were 400 patients, Hep patients, and we looked how the dosing are in this patient at 1 year. About 24% had 200 milligram twice a day, 28% had 100 milligram twice a day, and 31% had 50 milligram twice a day. So there is in Asia, more than the majority of patients received lower dose. But when you look at the other clinical parameters, systolic blood PP decreased by 2.2 millimeter mercury, eGFR by 2.1. Ejection fraction increased by 10%, LV end-diastolic volume index decreased by 18.7%, and anti-proBNP level decreased by more than 50%. So using just low doses in Korea, we have the same effect as in the randomized clinical trial. I'm going to touch a little bit renal protection because since the SGLT2 inhibitor, heart failure patient also or heart failure specialists are very interested in renal protection as well. So natriuretic peptide system AMP-BMP causes natriuresis and diuresis in vasodilator. It also has a receptor in the kidney. And we look at the kidney here. This is afferent atrial. This is the efferent atrial. This is macula densa. And this is the glomerular apparatus. When you give the natriuretic peptide to the patient, it activates granular cyclase, increases cyclic GMP level, and that inhibits the sodium reabsorption in proximal tubule. So this is the infusion of a AMP, and with the infusion, there's an increase in GFR here. The sodium exclusion also increases, so we have an increase in GFR, an increase in natriuresis and diuresis. So when you look at the mechanism of the SGLT2 inhibitor in diabetic kidney disease, in normal kidney, you have a sodium glucose reabsorption in the proximal tubule via SGLT2. If you have a diabetes, you have more glucose here in proximal tubule. So glucose will be reabsorbed along with sodium, so that you have less sodium in the distal tubule, and in the macula densa, you have a low sodium concentration. They will lead to the vasodilation via tubular-glomerular feedback. When you give SGLT2 inhibitor to this patient, it blocks here the sodium reabsorption in the proximal tubule. Therefore, you have more sodium in the distal tubule, and that restores tubular-glomerular feedback. So with the SGLT2 inhibitor, you have first drop in the GFR, but the slope of the GFR decreases flatter than the placebo. So you have a crossover after 1 or 2 years, so that you have survived, you have a more kidney protection after 1.5 years. So this is a drug that works in nephrons. So SGLT2 inhibitor causes afferent atrial vasoconstriction, lowers the intraglomerular pressure. RAS blocker dilates the efferent atrial, so you have a low pressure here. So when you give sacubitril/valsartan, you have a natriuresis like SGLT2 inhibitor in proximal tubule, and valsartan will act as a RAS inhibitor, so that you have a kind of dual protection for the kidney. So it's from Paragon study, when you're looking at the renal outcome, there is a 50% risk reduction for eGFR, ESR, or renal death in patients who are receiving sacubitril/valsartan, as seen here in the Kaplan-Meier survival curve. As for the eGFR over time, there is an increase in eGFR, and these two slopes are parallel to each other, so that you have less decrease in eGFR with the sacubitril/valsartan compared to valsartan alone. So let me summarize talk with this last slide. This is the what to do or what not to message from the ESG guideline. And as you see here in the last line, the sacubitril/valsartan is recommended as a replacement for ACE inhibitor in patients with HFrEF to reduce the risk of a heart failure hospitalization and death. It really emphasized that this is currently the best HFrEF, one of the best HFrEF drug that really improved the survival compared to enalapril. I thank you very much for your time and for your attention.
Thanks, Jinju. That was indeed a tour de force review of the ARNI class of drugs. So any questions from the panel or my co-chair, please jump in. If not, then maybe I can start out with one question before my co-chair drops in. In the guidelines, they say it's still a class 2B, but a class 1A to start ACE inhibitors. So in your point of view, in the Asia-Pacific context, there are so many zeros for the difference in terms of the p-value. What is then the use case for ACE inhibitor now? Because the drug was compared against enalapril and shows dramatic improvement, not just in combined MACE plus CV death. So why do you want to use ACE inhibitors when you can use sacubitril/valsartan in Asia-Pacific?
Yes, this is a very good question. I don't know why the ESC guidelines still have ACE inhibitor and sacubitril/valsartan at the same line. The consensus of the ACC and AHA, they recommend sacubitril/valsartan as the first drug. And if you can't use this, you can use ACE inhibitor. And if you can't use sacubitril/valsartan ACE inhibitor, then you can use ARB. I think we should use sacubitril/valsartan as the first line drug for HFrEF patient management. But the question is the cost, because it's 4 times more expensive than an ACE inhibitor in most countries. So if the cost is not the issue, then you should start with the ACE sacubitril/valsartan. And for those who in countries where sacubitril/valsartan is not available or the care cost is the issue, then you may start with ACE inhibitor, but not with ARB.
Thanks, Jinju. Dr. Lee, you have a question?
Yeah, a question regarding the dose of the sacubitril/valsartan. In the trials, more than around 50% of patients that are underdose. I mean, less than 100 milligrams per day, twice per day. What do you think about the dose and the beneficial effect of the ARNI?
Actually, there are studies that the higher dose, the better the outcome. But the one thing is that the paradigm-HF study or other study were mostly carried out in Caucasian who has more BMI and more body weight at all, more body surface area. So we're not sure whether we can directly apply this result to Asian patients with a lower BMI and more lower body weight. The second issue is that if you have a higher dose, then if you tolerate a higher dose, that means the patient is better condition than those patients who cannot tolerate the maximally tolerated dose. Let's say you have kind of selection bias. So we are not sure whether dose is the marker or the mediator of the drug, but you need to try to up titrate the dose, the maximally tolerated dose or target dose, because we do not have data for the let's say lower dose hypothesis or marker hypothesis. So I would try to up titrate dose to the maximally tolerated dose in the heart failure patient.
I do have initially, before Dr. Lee jumped in, also the same question about dose. We have in Asia a lot of patients who, because we give them a combination of many classes of drugs, they start out with 25 milligram BID, step up to 50. They really achieve dramatic improvement in NYHA class, BNP drop. They are very reluctant to increase dose actually. So are you saying that there's added dose increased benefits, even if they have achieved improvement in NYHA class and BNP levels?
The thing is that we don't have data. So we don't know. So if you look at the study, let's say the study with the carvedilol, the recommended dose is 50 milligram a day or 25 milligram twice a day. the clinical trial, the mean dose in clinical trial is 37 milligram. So even in clinical trial, you can't reach the target dose. The same is for valsartan. In Bell-Heft, the recommended dose was 320 milligram, but in that study, 240 milligram was the mean dose. So you can't reach the target dose in every patient. What you can do is you can up titrate the dose to the maximum of the maximum tolerating dose.
Thanks. Any questions for Dr. Park? Yeah,
Dr.
Cheryl.
Park, you mentioned that the ARNI had renal protective effect. So do you have the threshold, like how bad the renal function the patient has, that you may hesitate to prescribe the medication for them? And also for the patient already on hemodialysis, do you recommend them to use the drug as well? Thank you.
Yes, this is a very good question, because heart failure patient, 1/3 had renal impairment. And the patient with on HD were hemodialysis were excluded in the paradigm study or all other clinical trials. But with this drug more and more popular among heart failure patients, we have data on the use of the sacubitril valsartan in HD on patients with hemodialysis, and they were as effective as the other group. So I don't see any concern why not use this drug. You use the valsartan in HD patient in all kind of patient group. So in contrast to SGLT2 inhibitor, I don't see any threshold, eGFR threshold for sacubitril valsartan.
Thank you. Any last questions for Dr. Park? Maybe just the last one. You didn't go into normal or preserved ejection fraction for
Yes.
ARNIs. Maybe you can give us a parting remark on the ARNI use in HFpEF.
It's a very, very big complex issue. If you have a mid-range or the mildly reduced ejection fraction, let's say 40 to 50%, I'm sure that RNA works. If you have ejection fraction greater than 50%, let's say between 50 and 55, 57, the drug seemed to work. Because in the Paragon study, there was a subgroup analysis, the median EF was 57%, and it was effective in patients who had ejection fraction less than 57%. And the FDA had an approval for RNA in heart failure patients below normal ejection fraction because there were secondary analysis with the extended clinical outcome by including urgent heart failure visit. Because if you have a, let's say, DAPA-HF study, the clinical endpoint also included urgent heart failure visit, but in the Paragon study, you need to be hospitalized. So if you include the urgent heart failure visit, then the p-value becomes significant. And there was one of the reasons why FDA approved the sacubitril valsartan in heart failure with below normal ejection fraction. So we need more study, but I think you can use it for patients who has less than 55% ejection fraction.
Yeah, but probably not more than that.
Probably not more than that.
Yeah, thanks a lot, Jinju. So we're going to change tracks a little bit to Professor Rongroach to give an overview on the competing big class of drugs, the SGLT2 inhibitors. Rongroach, please.
Thank you very much, Jack, and thank you for introduction. I will focus my talk on the drug SGLT2 inhibitor as a frontline for heart failure patients, both reduced preserved ejection fraction and with and without diabetes. This outline of my talk, diabetes and heart failure, and detail of SGLT2 inhibitors in different group of patients, and look at Asian data and real-world data. First of all, as you listen to Dr. Park earlier, you listened to the benefit of ARNI in paradigm heart failure. In my talk, I will focus on SGLT2 inhibitor to the right. If you look at the graph of the benefit of the drug, you'll see that the graph separates very early for both class of drug. For SGLT2 inhibitor, the number needed to treat also 21. The p-value also very significant, and the hazard ratio was 0.74. Both study used CV death and heart failure hospitalization as the composite endpoint. Now we are talking about two different classes of drugs that have an emerging role in the treatment of patients with heart failure. This is patient with heart failure with or without diabetes. So you will you know that the global prevalence of diabetes increase. The projection is from 2017 to 2045. The number will be at least 200 million people with diabetes more. And similarly for heart failure, this is data from United States. You can project the increased prevalence of heart failure up to 2030 and maybe more. But this is mainly due to the increased size of elderly population and increased prevalence of heart failure. If you look at a study of diabetes and study of heart failure, you see the prevalence of diabetes in patients with heart failure approximately 30%. Also, similarly, if you look at a study of diabetes, you see the prevalence of heart failure in diabetes patients also around 10 to 20%. It's a huge number of population that overlap between diabetes and heart failure. When you have diabetes, you have a good chance of developing heart failure in the future, approximately 2 to 5-fold. And when you develop heart failure, you have increased risk of mortality and recurrent heart failure. The expected survival significantly decreased. But today, we're not talking about diabetes with heart failure. We're talking about heart failure with and without diabetes. Actually, heart failure is the very common presentation of cardiovascular disease in patients with diabetes. Mechanism of SGLT2 inhibitor. The drug increase glucose excretion in the proximal tubule. And when doing so, they not only affect the volume status of the patient, but they also affect cardiovascular risk reduction, glucose lowering, weight loss by approximately 2 kilo, systolic blood pressure lowering by approximately 4 millimeter mercury, left ventricular hypertrophy regression, and reduction of albuminuria by 30 to 40%. This is a reduction in cardiovascular risk factor and may have impact on the reduction of both heart failure and CV death in the future. This is evidence of SGLT2 inhibitor in the reduction of left ventricular hypertrophy. This is experimental in dapagliflozin between the drug and placebo. You see that left ventricular hypertrophy assessed by cardiac MR markedly reduced after 12 months of the drug. Also, the drug has been shown to decrease lung fluid volume. This is by defined heart failure study. More than 200 patient diabetes, random to DAPA versus placebo for 12 months. The drug significantly reduced lung fluid volume, and this can reflect to the reduction in NT-proBNP level and quality of life. In animal model, SGLT2 inhibitor has been shown to affect a decreased intracellular sodium and calcium. Therefore, the drug will balance calcium regulation within cell and reduction of the injury, cell injury causing by calcium overload. In clinical trial, the drug significantly increased hematocrit level. And from the calculation, they propose that the change in hematocrit increase can explain about 50% of cardiovascular death reduction and also the reduction of heart failure. The drug have differential effect on interstitial and intravascular border. In contrary to loop diuretic decrease interstitial and intravascular volume, but SH2 inhibitor significantly reduce interstitial volume, but no effect on intravascular volume. This is the drug that can explain also the benefit in heart failure reduction and renal benefit of SH2 inhibitor. Now, for the treatment of heart failure reduced ejection fraction, the cardiovascular outcome study in diabetes that have to be proved that the drug have no problem on CV death or major CV outcome. The drug has been found not only to decrease the reduction in MACE, but also significantly reduction in hospitalization due to heart failure, both EMPA, CANA, and dapagliflozin. This is the initial study before the drug has been tested in patients with heart failure. There are a lot of room for improvement in the treatment of heart failure, reduced ejection fraction. As you can hear that we have many new drugs for the treatment of heart failure reduced ejection fraction, but the residual risk remain high. This is after the implementation of ACI, beta blocker, and even with ANI, both treatment arm and placebo arm also have a high 1-year mortality rate and high 1-year heart failure hospitalization rate. I will show you the data on Emperor reduced and DAPA heart failure announced ESC 2019 and Emperor reduced in ESC 2020. This is number of patient follow-up time, primary outcome. Similarly, but DAPA also include urgent heart failure visit, ejection fraction less than 40 with high NT-proBNP level, and eGFR more than 30 for DAPA, more than 20 for EMPA. The proportion of diabetes in both trials is around 50%. DAPA is around 42%. Ejection fraction around 27. NT-proBNP almost 2,000. Both studies have a good proportion of patients receiving guideline-directed medical treatment, including ANI. This is the data. The primary endpoint reduction by 25% for Emperor and 26% for DAPA. Heart failure hospitalization reduced by 30% for EMPA and 25% for DAPA. And composite renal outcome reduced significantly for both for EMPA, but not for DAPA. Even the renal outcomes decreased. The benefit across all subgroups and excellent safety profile for both drug comparing placebo. Not only reduced composite outcome, they also found to have a reduction in atrial fibrillation with SGLT2 inhibitor from meta-analysis. And when you use the drug in combination with MRA, the incidence of severe or moderate hyperkalemia reduced by approximately half when you implement the SGLT2 inhibitor in combination with MRA. And for the reason of the DAPA heart failure study, FDA approved DAPA in May 2020 for the use of heart failure reduced ejection fraction with and without type 2 diabetes. The data for diabetes and non-diabetes for DAPA heart failure, you see the benefit in diabetes group and non-diabetes group is similar. Hazard ratio 0.75 and 0.73. And this is worsening heart failure event. Similar benefit for diabetes and non-diabetes. Hazard ratio 0.77 and 0.62. Renal benefit also similar for diabetes and non-diabetes. Hazard ratio 0.73 and 0.67. it has been published by McMurray and Milton Packer that the sequence, the original sequence, should be changed due to the drug, the three classes of drug, ACI, ARB, beta blocker, MI, need titration and need to be one by one or one combination, and take time before the drug achieve guideline recommendation dose for the three class of drug. They propose a new sequence and start and add new medication every 2 weeks. And step 3, 4 weeks, you have the four class of drug together. This is a purpose, and it has been changed in the guideline, especially ESC guideline that just announced 2 months ago. SGLT2 inhibitor not only have the role for treatment, but also for prevention. The data from DECLARE study, dapagliflozin, which this study have 60% is risk factor without documented cardiovascular disease. The data show that CV death hospitalization reduced by SGLT2 inhibitor by 17%, significant p-value for superiority. And when you look at patients in risk factor group without cardiovascular disease, the drug has been shown to have a significant reduction in heart failure in the future and also have benefit in the renal outcome. It has been announced during the ESC right after ESC guideline announced for Emperor Preserve. As you aware that for patient with heart failure preserved ejection fraction, there is no specific class of drug that have significant impact in cardiovascular outcome of the patient. The drug that have benefit for heart failure reduced have been studied with heart failure preserved, but also negative trial. Emperor Preserve is the first trial that have that shed the light in heart failure preserved ejection fraction. This is phase 3 in patient with heart failure preserved ejection fraction EF more than 40 with elevated NT-proBNP. Have the primary composite endpoint is CV death and heart failure hospitalization, EMPA versus placebo average for up 26 months. Baseline corrected diabetes 49% in both groups. New York Heart Functional Class 2 mainly 80%. Average NT-proBNP around 9, almost 1,000. Atrial fibrillation 50%. GFR average of 60 have received a standard medication. The data in this study show that the composite outcome reduced by hazard ratio of 0.79, the p-value 0.0003, and heart failure hospitalization reduced with a hazard ratio 0.73, p-value less than 0.001 for dapagliflozin, comparing to placebo in heart failure preserved ejection fraction. If you look at individual composite outcome, CV death hazard ratio 0.91, not significant reduction. The main primary outcome benefit is driven by heart failure hospitalization with this very significant impact on the outcome in this group. Look at interaction between diabetes and no diabetes. No interaction, which means that also the benefit in diabetes and no diabetes is similar. Look at race, Asian population and white population, similar benefit. The trend toward a little more benefit in Asian population. GFR more than or less than 60, similar benefit. Ejection fraction, there's no significant interaction, which means that have no significant interaction on ejection fraction. That even there's a trend toward less benefit in patients with very good ejection fraction. Cause of heart failure have no significant difference. New York Heart also the same, and NT-proBNP use of standard medication also no significant interaction on the benefit of EMPA in patients with reduced, and this is 3 pre-specified composite endpoint. You see that the primary endpoint reduced by 21%, and heart failure hospital reduced by 27%. GFR decline, slope GFR decline also significantly reduced with the p value less than 0.0001. Benefit of SGLT2 in heart failure, the data in patients with reduced ejection fraction, you see the benefit in Asia versus white, p interaction 0.01. There's a trend toward more benefit in Asia population from the data of DAPA, heart failure, and Emperor reduced. And also, as I showed you earlier for PRESERVE, there is no second interaction for benefit in Asian population in PRESERVE as well. The guideline, ACC guideline 2021, recommend ANI, the one that Professor Park mentioned. ANI is the first line and prefer over ACI or ARB. The SGLT2 inhibitor is this one. After this one, you add SGLT2 in patient meet GFR criteria functional class 2 to 4, you can have the flow drug, because right after you have this one, you can add this one. For ESC guideline 2021, this is the 4 class of the drug together as class 1 recommendation, and then you can up titrate the drug later. For SGLT2 inhibitor, you have no need for up titration, single dose, and you can just initiate the drug. Professor McMurray proposed the 5 pillar of heart failure reduce, 5 pillar but 4 pill. You can have ANI, beta blocker, MRA, and SGLT2 inhibitor all together. Recent publication last month, drug layering in heart failure. As you heard, many questions. Which drug you start first, and how to manage patient when you diagnose heart failure, reduce ejection fraction. This study proposed patient profile relevant to drug layering according to heart rate, blood pressure, and the presence or absence of atrial fibrillation. They propose that you can start this for group of drug, but you start which drug first, or titrate the dose of medication, which one first, and how to caution. You look at blood pressure, low blood pressure, low blood pressure, low heart rate, and normal blood pressure or high heart rate. You use this one. For the presence of atrial fibrillation, you can focus on anticoagulant, atrial fibrillation, low blood pressure, normal heart rate, normal blood pressure. This is a good recommendation. Propose how you look at patient phenotype and start which group of patient and how to titrate. The paper also recommends that renal dysfunction and abnormal potassium should be emphasized on every step of initiation or titration of medication. We have real-world data for comparing SGLT2 inhibitor versus standard medication of diabetes. We are waiting for more real-world data on the use of SGLT2 inhibitor for patients with heart failure, reduce or preserve, because the drug is just approved by FDA for this indication. The real-world data for diabetes, comparing for EMPA with other class, for example, DP4 inhibitor for a large group of patients, you see that the drug comparing to DP4 have benefit in the reduction of composite outcome for mortality and for especially for heart failure with a hazard ratio of 0.5 to 0.6. Also for dapagliflozin in the CVD real study compared to other class of medication or DP4, the drug has been shown in real world to reduce major adverse cardiac event, reduce heart failure, and also reduce mortality. This is not only in Western population, also in Asian population. So for summary, SGLT2 inhibitor is a class of drugs that have benefit in patients with heart failure with and without diabetes. And the data, we have the new data that not only reduce ejection fraction, but also for preserve ejection fraction. More data is coming for deliver in patients with dapagliflozin in preserve ejection fraction. Therefore, SGLT2 inhibitor have benefit in patients with the DM document cardiovascular disease and heart failure reduced, and now we have the data in preserve ejection fraction. And now, in the past 30 years, we have many class of drugs that have benefit in the reduction of mortality and heart failure in patients with heart failure, reduced ejection fraction, and we have data in preserve as well. Now, after implementation of SGLT2 inhibitor, mortality reduction total in combination with other guideline-directed medication treatment will be reduced by 70 to 80%. This is an exciting moment in heart failure field. Two new treatments, ARNI and SGLT2 inhibitor, has been found to have benefit in patients with heart failure, reduce ejection fraction, reduce composite endpoints in patients with preserved ejection fraction. The challenge for us is to bring this medication into practice. We must not take excuse for not using the benefit that have been shown to have a reduction or improvement in cardiovascular outcome. Our patients need them, and the patient need them now. The benefit occur very early. You just need to initiate the drug for appropriate patient. For SGLT2 inhibitor, you need no titration. And the term stable heart failure should not be used because there are no such patients that have stable heart failure. The patient with stable heart failure can have exacerbation of heart failure anytime. Thank you very much for attention.
Thanks, Ron Roach. Again, a very excellent tour de force. So we have two blockbusters head to head. It's almost like a debate between Jinju and Ron Roach, actually. So any questions from my panel first before I jump in? Anyone want to raise a query?
I just want to ask a quick question. Do you think the SGLT2 has class effects? I mean, all of the SGLT2 has the same effect and benefit?
From the initial data in both animal and human study for mechanism that people try to explain, all SGLT2 inhibitor seem to have similar action on fluid status, on glycosuria, on change in cardiovascular risk factors. Therefore, it is possible that it can be class effect, but in the recommendation in the guideline, they based on evidence from clinical trial that has to prove that the drug have benefit in such patient. Therefore, in the guideline, for example, ESC guideline, they just mention DAPA and EMPA for heart failure reduced. They do not mention just the whole class of drug, although it is reasonable that the drug may be class effect. For example, for other drugs, such as soloist and score, in patients with sotagliflozin, they also study patient diabetes and heart failure. They also have the data in patients with preserved and reduced, but only for diabetes patients, that shown to have benefit in the reduction of events. Therefore, I believe that it may be class effect. But for recommendation or follow guideline, you have to focus on the data from clinical trial. Thank you. Thank you.
Any other questions from the panelists?
A very short question regarding the preserved. How about because we have the more beneficial effect in terms of the Asia population for the heart failure with preserved ejection fraction. Do you think that's because of the half pop in Asian people are more obesity?
I believe that this could be a possible reason. many studies shown that heart failure in Asia have a different or unique entity comparing to Western population. This is both reduced and preserved, especially for preserved ejection fraction. You see that Asian population have a presentation of heart failure more early than Western population, and the heart failure may be problem in Asia from the population size, may be more burden comparing to Western population. I think that it is possible that Asian population have a unique entity of heart failure preserved ejection fraction, and this is waiting for more study. Yeah.
Thank you. Any other, Siwei?
Yeah, I have a question. I think this is very well established that all these heart failure medicines do have very benefit effects both on mortality and morbidities. Do you think that one of the challenges we have is putting patients on so many medicines? Will there be a benefit of doing what I call combination drug that will definitely improve compliance? And what are your thoughts on whether there's anything in the pipeline? Just combining, 4 drugs into one.
Yeah, I think that this is a very good idea for combination drug or a single pill of drug combination. But the main problem there has been shown that a single pill combination has been used effectively, especially in patients with hypertension, right? But for patients with heart failure, the problem is mainly for the dose of medication for standard medication. ACI, ARB, ARNI, beta blocker, you have very wide range of the dose of medication. You have to titrate the medication, especially when you have low blood pressure, use with very low dose and slowly up titration. It would be a little difficult to make a single pill with different dose of medication. You mean it have to be many strength of medication in combination. The concept is well taken for SGLT2 inhibitor, because SGLT2 inhibitor you have single dose, you need no titration. But the problem will be when you combine the guideline directed medication with SGLT2, that would be very difficult for single pill in the concept for up titration of medication. It would be challenge, I think. Thanks.
So maybe I can help.
Yeah.
Sorry, Siwei.
I would have thought that during up titration phase is not ideal, but when it's stable, it is really a good idea because it will definitely help with compliance and possibly driving the cost down, because having one drug, probably we can argue that as a group we can give a bit of pressures. Well, it's all to benefit patients.
Yeah, when you have stable dose, it's very good option. And in Asian population, I think we need more data on cost effective or cost utility analysis of the new medication. Yeah.
So maybe a last question for Jinju, if you can chip in here. We heard both pieces. You looked at NT-proBNP. In the clinical practice, how low should you try to up titrate drugs to target and push down the BNP? What levels? Is it absolute percentage reduction or absolute level that you're targeting for in clinical practice?
This is a very fancy concept to titrate your drug according to BNP level, but the concept has failed. So that I would use NT-proBNP level to diagnose heart failure, not to monitor the response to medical therapy, because it doesn't work. It doesn't work yet. So you up titrate drug to the guideline, take the medical to the maximum tolerated dose, but not according to BNP level. But if you follow the BNP and there's decrease in BNP level, you can guess that the patient's doing well or not well. And I think I don't use BNP level for monitoring of a drug effect in my clinical practice.
Thank you, Jinju. Last question for Rongruch. In a patient with CKD, maybe stage 3, would you actually start both ARNI as well as SGLT2 inhibitor at the same time if you're treating a heart failure patient?
Yeah, I think that we can start both drugs at the same time in CKD stage 3, and we follow them closely and monitor both kidney function and electrolyte, because once you start this drug, you need to follow patient at least the first week after you start and monitor monitor kidney function and electrolyte. You can see from both clinical trials that the benefit of both drugs occur very, very early. In a matter of 10 to 20 days, you have a significant reduction of event. I believe that you don't need to wait time to see the benefit. And whenever you have opportunity, you can start. You can unless the patient have very low blood pressure, you have to be cautious when you use ARNI. If the patient have good blood pressure, you can start them at the same time. Yeah.
Thanks, Roach. I would now like to transit to session 2 and have Professor Lee introduce the next speaker. Thank you.
Yeah, thanks for the previous speakers talked about the SGLT2I and the ARNI. Then we move to the next one. That's will be presented by Dr. Yu. And the title, the AV junctional ablation plus CRT versus catheter ablation rhythm control in heart failure reduced ejection fraction complicated with the persistent atrial fibrillation from catheter APAF CRT to the real world. Dr. Yu, please.
Okay, thank you, Professor Lee, for a kind introduction. Today, my task is to compare the strategies of AV junction ablation plus CRT versus catheter ablation rhythm control in half-ref patient and persistent AF. Before I jump into the two trials, I'd like to spend 1 minute talking about the interplay between heart failure and AF. First, they share many risk factors, including age, hypertension, diabetes, obesity, and ischemia. Second, many patients with heart failure develop AF later, and the AF itself can cause heart failure through high heart rates. And third, the vicious cycle. The existence of anyone will worsen the condition of another. The development of AF in heart failure doubles mortality, and the development of heart failure in patients with AF is associated with threefold rise in mortality. So in Castle AF, the hypothesis is to prove the catheter ablation for AF can improve outcomes among patients with heart failure. In this patient, in this study, the patients with symptomatic paroxysmal or persistent AF were enrolled, and the patient had to have ejection fraction below 35%. The results of this study is very impressive, that almost 40% of the risk reduction of the primary endpoint, which is death or hospitalization for heart failure. This result was equally driven by either death from any cause or hospitalization for heart failure. So I think AF ablation also offer the primary and secondary clinical endpoints. Other than death and heart failure hospitalization, you can see here the CV death and CV hospitalization are also reduced significantly. So I think for a patient with AF and half-ref, the AF ablation should be attempted if no other indication. But there is actually a criterion that had not been paid attention to in the enrollment criteria. That is, the patient has to be failed or intolerant of anti-arrhythmic drug therapy. This actually reminds us the recent East FNet-4 trial that published last year in NJAM, that when the patient could tolerate anti-arrhythmic drugs and are diagnosed early, meaning within 12 months, the patient can benefit. The patient can actually benefit from rhythm control therapy, either by drug or ablation. Also in East trial, we can see even in the rhythm control group, in the beginning, only 8% of the patient received ablation. And at the end of the study, at the 2-year, only 20% of the patient received ablation. So this is meaning that most of the patient could tolerate anti-arrhythmic drugs and can be well controlled by these drugs. And among this trial, there were a small group of patients with low ejection fraction, around 10 to 15%. And because of the smaller number, you can see on the right-hand side that the p-value is 0.12. But still, you can see the trend that early rhythm control can help the patient for risk reduction. So from the East and Castle trial, we should rhythm control the patient with drugs if tolerated, or if they cannot tolerate the drug, we can try ablation. But this finding is interestingly very similar to the subgroup analysis in Castle AF, showing that the patient with a New York Heart Association functional class 2 can actually benefit more than class 3. And the patient with higher ejection fraction can benefit than lower. This implies that we may want to treat the patient early and timing. Another thing is that in the Castle AF, people criticize that during the enrollment period, up to 87% of the patients were actually excluded from the study. So we may wonder whether the results could be generalized to clinical practice. So last year, there was an interesting paper using a large US database and identify the patient with AF and heart failure patient. And you can see in this cohort, only 70% of the patient would be eligible for the Castle, using the Castle AF criteria. So it's just a minority of the real world population. And also you can see the benefit is around 20%, much less than the Castle AF showed. But there's actually a significant benefit from the cohort. And if you compare the figure on the right-hand side and on the left-hand side, you can see the curve is very similar. So you might say the result of Castle AF can be generalized to most of the patients in the real world. So another interesting is that even though in the Castle AF patient, when they enroll a patient, the patient has to be like intolerant to anti-arrhythmic drugs. But you can see in the table that at the end of the final follow-up, there are like 1/3 of the patient in both groups taking anti-arrhythmic drugs. Even though in the beginning they are claimed they are not tolerant. So I think that is because in the protocol that the effort, even in the pharmacological group, they recommend the PI to try to maintain sinus rhythm even in the control group. So for the patient who had failed atrial fibrillation, meaning they don't want to do the ablation or they had failed atrial fibrillation with early recurrence, what we should do next? Usually, I think we will give medications for rate control, either beta blocker or digoxin, even though these drugs do not show survival benefit in the clinical trials. We actually do not have many choices. For those patients, rate control is inadequate. We then put a pacemaker and ablate the AV junction. The concern is the ultragenic ventricular desynchrony that created by traditional RV pacing. So maybe physiological or biventricular pacing can compensate the detrimental RV pacing. So now let's look at the APAF CRT mortality trial. The inclusion criteria is the symptomatic permanent AF, meaning lasting more than 6 months, either considered unsuitable for AF ablation or who had done ablation but failed. Another inclusion criteria is the patient has to be hospitalization for heart failure in the previous year, but they don't set the criteria of LV ejection fraction. In this study, there are 140 patients randomized, either to ablation and CRT arm or drug arm. You can see here that among the 75 patients, there were actually 18 patients, almost 25% of patients cross over to ablation and CRT. So this may dilute the effect of this study. So if the outcome shows significant benefit, risk reduction of all-cause death and or hospitalization for heart failure. If we further look at the patient with reduced ejection fraction, we can, of course, the case number is, because it's divided, now the case number is even smaller. So in the patient with ejection fraction below 35, the difference become no significance, but you can still see the trend that the group of ablation and the pace can reduce the primary composite endpoint. So the benefit of these two trials in Castle AF, I would say, is more clear that because we avoid the potential toxicity of the anti-arrhythmic drugs by using ablation to try to maintain sinus rhythm. But in APAF CRT trial, the mechanism would be more complex because comparing the two trials, the study group had more strict rate control, better rate regularity, and also they use biventricular pacing. So you don't know which is the main factor that drive the benefit of this treatment strategy. So the question is, if we can get good rate control or good regularity just by medication, is it still better to perform AV junction ablation with biventricular pacing? Or what would happen if we use the currently hot topic about his bundle pacing or left bundle branch pacing? The data would be the same. We don't know yet. So this is the picture of the AF spectrum, the natural course from paroxysmal to persistent, then go to long-standing, persistent, and permanent. Of course, the patient with treatment, the patient with persistent AF can go back to paroxysmal, and it is common in the clinical practice. So in the EAST-FNET trial, we can say for the patient in the early stage, we would try to reason control with either medication or ablation as early as possible. But most of the patient will fall into this category that the patient either paroxysmal or persistent or long-standing, they can try to do ablation to help maintain sinus reason. But for the patient who had failed ablation or don't like to receive ablation, they can try to ablate the AV junction and implant CRT for PACE. So let's look this common scenario in the clinic. If there's a 73-year-old man came to your office and he had non-atrial fibrillation for 5 years and had progressive heart failure symptoms for the last year, what would be your recommendation? I think I would probably do the echo first to see his atrial and ventricular condition. The echo data said there's a reduced ejection fraction with enlarged left atrium. So if you are considering cathal AF, then you would recommend PV isolation. Or because the AF history has very long, more than 5 years, we may recommend AV junction ablation with CRT. But actually, if we now know that with cathal AF criteria, the patient has to be intolerance or failure to anti-arrhythmic drug therapy. So for this patient, we may try to use the drug first to see whether it can tolerate. Or for the second strategy, the patient may try to do AF ablation first, but of course you can say, oh, it's almost a long-standing AF. It may not be responsive to ablation, but still you can try before you do AV junction ablation. So if the patient doesn't want to do any invasive study, still it's always okay to go back to the guideline-directed medical treatment. The ESC and ACC both announced new guideline for heart failure in this year. And also from the two previous experts, we know that the drug is very promising and maybe try first. And actually those drugs, both ARNI and SGLT2 has some evidence showing that the AF burden can be reduced by this medication. So here is my conclusion that the treatment strategy has to be individualized according to the patient's age, comorbidity, and his own preference. AF ablation can avoid anti-arrhythmic drug toxicity and serves as a good alternative to help maintain sinus reason in half-rep patients. And pace and ablate strategy showed beneficial effect on mortality and heart failure hospitalization in HFrEF and permanent AF patients. However, for me, I think more questions had raised from this study. I think we need more data to jump to the conclusion. Thank you.
Thanks for a nice presentation from Professor Yu. This is open for discussion. Any question from the panel or from the ground?
Can I start off with a quick question for Cheryl? You mentioned on that big topic, your patient, for example, you showed with heart failure, and you said maybe can go with antiarrhythmic drugs. I mean, ESC said that this patient probably is not suitable for drugs like sotalol with poor ejection fraction. And the antiarrhythmic drug that comes to mind will be amiodarone, which long-term is not a good drug to use. So what antiarrhythmic drugs are we talking about in this day and age for chronic AF?
Because today's we talk patient with HFrEF. So you are right that in this population, the only good antiarrhythmic drug was amiodarone. But as you said, that there's long-term, there's complication if you use long-term. So for this patient, I would just try a short-term amiodarone. And then if the reason doesn't convert, I would recommend ablation to try to convert the reason. I would not use amiodarone for long-term.
We know that amiodarone is not a very good candidate agent for long-term control of atrial fibrillation. And there are so many questions regarding the persistent or permanent AF. Also, some questions regarding the either biventricular pacing or from his bundle pacing. And since there are so many uncertainties, so would you have any suggestion that how to individualize this kind of patient? I mean, of course, in the early stage, the Parsons atrial fibrillation, I think medication is a good idea at first. But for persistent AF or even permanent AF, that actually, if we define it as a failure from previous ablation, then would you suggest straightforward to have a more aggressive ablation and biventricular pacing?
Because I think there are some issues to be considered. First, if we do the AV junction ablation, we will make this patient become pacemaker dependent.
Sure.
Actually, in some situations, that would be very dangerous for this patient. For example, if the device become infected, you have to remove and implant a temporary pacemaker. So
sure.
I personally would put this strategy at the very, very last, like a reservoir. And like I said, I think there are many questions to be answered. For example, whether I would give CRT or I would give left bundle pacing. For now, I don't have the answer. So I would not be comfortable to recommend this strategy early for the patients. And but for those patients with HFrEF and permanent AF, I would recommend ablation trial first.
So you mean ablation of atrial fibrillation, but not the AV node.
Yes.
Am I right? Okay.
Yes.
And you would put on the biventricular pacing in early stage. As the ESC guideline, based on ESC guideline 2021, the CRT for those dependent on pacing is moved upgrade.
Oh, if the patient is already pacemaker dependent and already RV pacing dependent,
mm-hmm.
And then the ejection fraction dropped below 35%.
Mm-hmm.
Of course, it's I guess it's class 1 indication to class 2A indication to upgrade to CRT. Yes.
Mm-hmm. But you will be hesitant for the AV node ablation, right?
Yeah, I really hesitate to damage the AV junction.
Okay.
I
Any
have
other
seen some
question?
patients that work quite well with just ablating as a last resort and do a CRT-D. Some of them have done incredibly well. Can I just ask you guys, whether Rong Roach or yourself, the subgroup who are older, whether it's HFpEF or HFrEF and they have AF, what is the age threshold for ablation nowadays? Is there one? Do you stop ablating when they are 70, 75, or age doesn't play a part anymore?
Yeah, I think age is very important for a physician to recommend a strategy to a patient. So I don't think there is a gold standard, but for my personal practice, I would set like 80 as a cut point. So if the patient are above 80, I would recommend pacemaker more.
Yeah, I think it depends on the functional status and
yes.
quality of life of the patient as well. It's not only the age. If the patient
Yes.
spend their active life, their brain is okay, maybe we can run invasive strategy as well. Thanks.
Yes.
Thank you.
So we are much left behind. We have to move to the next speaker. That's Dr. Hu from Singapore. The presentation is entitled "The Functional Mitral Regurgitation and the Outcome in Heart Failure with Reduced Ejection Fraction: The Implication in Patient Selection for Mitral Clip Therapy." Dr. Hu, please.
Thank you very much, Professor Lee, for the introduction. And I thank the committee for inviting me. And I think this is a very interesting meeting for me, learning from all different colleagues and really truly representing what I call heart team. And this is my disclosure. I just want to say that I'm an imager and not a heart failure specialist, but I'll do my best to just give you an overview of functional mitral regurgitation, how we should manage them. I think just a quick overview on mitral valve apparatus is very complex and very dynamic. In fact, it has got so many components, and more importantly, with respect to our today's talk, is the fact that the left ventricle is the one that is abnormal. Sometimes, just that being the case, we have had difficulty because the mitral valve, because of the geometry of left ventricle remodeling, even though the mitral valve leaflet is normal, it can cause mitral regurgitations. And typically, we see that in terms of Carpentier classification, that of type 3B classifications of functional dysfunction of the mitral valve apparatus, as well as at the same time with chronic mitral regurgitation, there's annular dilatations. The key problem of functional mitral regurgitation in patients with heart failure is truly that of leaflet tethering. And that's because of what you see here in the right panel, where the left ventricle is very full, with ventricular remodeling, head muscle displacement, causing tethering of the mitral valve leaflet, resulting in mitral valve malcoagulations, resulting in mitral regurgitations. Two types of tethering patterns we see. One is that of asymmetrical tethering due to regional left ventricular remodeling, typically seen in posterior myocardial infarctions, where the coagulation point is at the atrial surface of the posterior leaflet, causing posterior leaflet restrictions. And sometimes when we see this, we can mistake this as an anterior prolapse. It's actually a pseudo prolapse of the anterior leaflet, and the mitral valve coagulation do not go beyond the annulus. That's why it is not a degenerative mitral regurgitation. Typically, in this case, you get regurgitation jet that is very eccentric, posteriorly directed. The other common case that we see is a symmetrical tethering, that of a LV global remodeling, where you have dilatation as well as symmetrical tethering of the mitral valve, resulting in severe mitral regurgitation that is directed centrally along the coagulation. Because of the chronic functional mitral regurgitation or any sort of mitral regurgitation, you can have atrial fibrillations, and that is well described by previous speaker. And in this case, you can have very marked mitral annular dilatation in the presence of severe mitral regurgitation as well as atrial fibrillation. And you can have eccentric mitral regurgitation as well because of the deviations of the posterior annulus. All said, pathophysiology or FMR is really very challenging. There is a degree of leaflet tethering, whether it is mild to severe, and the MR is dynamic. At the same time, really it is an interplay between the reduced closing forces because of poor LV function, as well as increased tethering forces because of the geometry of the LV. So this interplay results in degree of mitral regurgitation that is hard to predict. In fact, the mitral valve tethering has been described and has implications in terms of success of mitral valve annuloplasty, and that has been well described. Particular for mitral clip edge-to-edge repair that is important for our talk today is the fact that we have to analyze really what is the morphology of the mitral valve. Usually there is extent of tethering, the coaptation gap, as well as the coaptation length is important. Also, in the long axis of the TE, we want to look at the leaflet as length because it has implications for the type of mitral clip that we put in, as well as whether there is any leaflet classifications or the baseline mitral valve gradient. We all know now that when it comes to definition of severe functional mitral regurgitations, the cutoff is the same as for the primary mitral regurgitation, at least in American guidelines. And this is the EROA of more than 40 or regurgitation fractions of more than 50%. To make the diagnosis a little bit more challenging for functional mitral regurgitation when it comes to assessments of severity is the fact that it is very dynamic, especially in the FMR. In loading conditions, hypertensive state can cause more worsening of MR. Looks like the MR is more severe. Patient who has low blood pressure or under sedation, such as during TE, is actually much more reduced, so we may underestimate MR severity. Best to say that transthoracic echoes is what we use for assessment of severity, whereas for transesophageal, we're using it best to assess the mechanism of MR, to exclude degenerative causes, for example. Sometimes with good medical therapy, as previous speakers have spoken about, reverse remodeling does help, and we have to optimize medical therapy, and then we assess the mitral regurgitations. At the same time, sometimes exercise to review the symptoms of the patients, although the exercise stress echo do not specifically has got very much diagnostic, has got not much management plan, although to say that this patient is probably more brittle and we have to closely monitor that. In terms of the outcomes for patients with FMR, I think this is well spoken a lot from the previous speaker, so I shan't delve too much into it. Suffice to say, EROA of more than 0.2 or 20 millimeters square seems to suggest that the patients will have worse outcome, whether because of the MR per se or because of the LV dysfunctions. We are not sure. What is the current outcome data shows in the contemporary patients? Just looking at the mitral FR as well as cohort study that include patients of contemporary patients that has got majority of them on medical therapy that includes the three pillars, maybe not the SGLT2, that shows that 30 to 40% will actually die in 2 years. In fact, in the cohort, about 40 to 50% will die after 3 years. So it's actually a huge mortality problems in patients with functional MR. So in this context, probably reducing the MR helps with the reverse remodeling, and reduce the MR may perhaps increase or change the prognosis of the patients. You know as well that from the surgical data, it's quite disappointing in terms of mitral valve repair as replacement. The edge-to-edge repair using the transcatheter method without open heart surgery using the clip methods in the percutaneous manner does seems to help, especially if you have the data from the co-op. Here, I would like to discuss the two studies that included in terms of randomized study that in mitral France as well as co-op trial. That is discordant, and we'll go through it slowly. Mitral France study included all heart failure patients with the mitral regurgitations in class 2 and above, and they looked at the outcome in terms of randomized into medical therapy with guideline directed kind of medical therapy or a mitral clip on top of medical therapy. In 1 year, the heart failure as well as death in terms of primary endpoint has no difference. This is in great contrast to the co-op study that randomized 600 patients, 2 times the number we get in mitral France, and then they actually look at 24 months as the primary endpoint is heart failure hospitalization, randomized to either device therapy or only medical therapy alone. For the device therapy, it's important to say that they actually have to be optimized also on medical therapy with the heart failure expert to educate that the patient has been optimized medically before randomization into either medical therapy alone versus on top of that with the device. clearly shows that the device has got benefit in terms of primary endpoint, very nice, big p-value, and more importantly, over 2 years, number to treat to prevent heart failure hospitalization is that of only 3 patients. What about all-cause mortality? Also, you can see that in CORD-OFF, there is benefit in terms of all-cause mortality with number to treat of only 6 over 2 years. Then the real question is, why are their CORD-OFF results so different from the mitral FR? The possibility actually probably stems from the fact that the EMA criteria is different. In mitral FR, you include patients with EROA of more than 0.2 or more than 20 meter square with LV dilatation size more marked than the CORD-OFF. You can see here that in the mitral fronts, the mean LV dimension in terms of volumes is 135 and the EROA is 31, compared to CORD-OFF, which has got smaller LV volumes and the EROA of at least 41 millimeter square. What is important is they must be on optimal medical therapy, and this is adjudicated by the heart failure experts in the CORD-OFF trial. They have to go through these heart failure specialist adjudications, and they must be on maximum tolerated therapy before it's randomized. And even before randomizations, there is echo collab to adjudicate that the patient truly has severe mitral regurgitation based on the criteria that is explained above. So a lot of controls here with heart failure therapy as well as the echo collab. And of course, when it comes to outcome, it seems that patients with a CORD-OFF study do have got better outcomes at 1 year with more reductions in EMA results, which is less than 2 plus EMA in about 95% of the patients with CORD-OFF. Probably reflect the fact that when we have very extensive LV remodeling, the MR reduction with clip may not be that ideal. And that's just guessing from the mitral FR, where there is very extensive LV dilatation, not so much of MR in the baseline. So just key inclusion to highlight in CORD-OFF study that there is a lower limit of LVEF of 20% and an upper limit of LV end systolic diameter of 70 millimeter that is set so that all these patients that is beyond this limit are excluded, because believe that those people with extensive LV dysfunctions, they have so advanced disease that their prognosis will be dominated by LV dysfunction rather than MR alone. Hence, FMR is truly a heterogeneous group. And this concept of proportionality of MR in patient LV dysfunction has been introduced by Graven and colleagues. What Graven and colleagues has really demonstrated is using the Gollin's formula to calculate the effective orifice area or regurgitation fractions of the volumes of the MR. It is really dependent on the left ventricular size in terms of volumes and ejection fractions. It is to say that when we assess or when we look at patients with FMR, the MR severity needs to be described in context with the degree of LV dilatation. This is akin to looking at aortic stenosis. When we calculate aortic valve area, we actually take into consideration the LVEF and stroke volume. So we should do the same when we look at patients with FMR. The effective orifice area, for example, in the patients with LVEF of 30 and regurgitation fractions of 50, that means it's severe. If the patient have normal LV volumes, to satisfy a severe functional MR by these criteria are more than 50% regurgitation fractions, they would have an effective orifice area of about 0.2. If you have LV dilatations, as any of the patients we normally face in patients with chronic heart failure, they tend to have LV that's dilated. To satisfy the severity of MR that is more than that should have an effective orifice area of at least 0.3. And if you have a patient with very marked LV dilatation, to have severe MR in this definition has to have effective orifice at least of 0.4. And if you have a patient who have low blood pressure and a high grade and a high LA pressure, then during systole, usually the MR severity, MR regurgitations Vmax is actually less than 6, usually about 4. So this tells me that if you have a high MR severity in terms of the Vmax, you should take that into consideration as well, because these patients with low blood pressure, you probably need to have a higher threshold for EROA before you say that this patient is severe. So really, interpreting the EROA has to take into considerations the LV volume as well as the blood pressure of the patients. Why is it important? Because we need to use some sort of concept to explain the MR dominant versus an LV dominant as a driver for decompensation in patients with heart failure. And this is probably summarized here in patients with POAP and mitral FR. Mitral advanced patients can mean LV volume that is dilated 252 and effective oral area in terms of MR survey of 0.3. And this is probably proportional MR in the degree of LV dilatation or dysfunction. And this is in comparison in POAP, the patients has got smaller LV volumes and effective oral area is greater. So the MR is more on disproportionate to the level of LV dysfunctions. You can then see with this concept of proportionality that any patients with EROA of less than 0.2 tells me that, especially when the left ventricle is dilated, tells me that this is probably not the results of MR, but because of the results of LV dysfunctions. This is an inadvertent consequence of LV dysfunctions that the MR will probably be around 0.2 and below. So we have to take this into considerations when we examine patients with severity of MR, especially FMR. Thank God, at least lately, we recognize the limitations of doing EROA of MR more than 0.2, for example, in previous guidelines. And this is just to say that we have to interpret, select patients whom we think MR is of importance in patients with LV dysfunctions. We pick those that is set a cutoff 0.4 and above. We are actually encompassing a broad spectrum of LV dysfunction with there's a degree of LV dilatations. So anything less than 0.2 probably is consistent with proportional MR, whereas MR less than 0.2 is probably proportional MR, and MR more than 0.4 is probably severe functional MR. And this is summarized in these slides that shows that if you have proportional MR, the MR severity is consistent with the degree of LV dilatations, then the treatment is really to aim at doing medical therapy, reducing the left ventricular volumes by reverse remodeling, and then targeting the MR will actually improve. And in contrast, those with disproportionate MR, you have LV that is not so big, but you have some sort of regional infarct, typically that of posterior wall of the LV, and then you have the disproportionate lot of MR in relation to the degree of LV dilatation. Here you will need, on top of medical therapy, some sort of intervention. And then you include a CRT if the patient has left bundle branch block, where you want to synchronize the left ventricle, all segments to have reductions in MR. Suffice to say that all these concept of volumes and effective orifice area in terms of MR with respect to volumes, it is a conceptual framework. It is derived from the Gaudian's formula. Hence, the volumes and the EROA values are not echo-based values. So when we apply this value, we shouldn't apply the absolute values in our patients that uses echo measurements, because there is a lot of variability and there's a lot of limitations with echo alone. But the concept of big LV, not so much MR medical therapy is the treatment, and whereas patients with small LV, a lot of MR, after optimizing medical therapy, we should think about MitraClip. This is just summarizing the mortality benefit we've discussed, but suffice to say, for MitraClip, it's very strong predictor of good outcome. So we should always think about that you have another therapy to treat this group of patients that has poor outcomes anyway. In terms of conventional versus comprehensive therapy, we now know that there are 4 pillars. At least comparing those who are on 4 pillars, they will have a gain of at least 8 years for those who are 55 years of age, hence highlighting the importance of medical therapy. SGLT2 is recently proven in year 2019, so we mustn't forget this, and we know this very well that the 4 pillars has to be instituted early. So we don't have a good single parameters in terms of imaging criteria for selecting those who are symptomatic from severe functional mitral regurgitation. We all now have to go through this algorithm of optimizing medical therapy, get our heart failure folks to optimize this. And at the same time, after they have been optimized, we should repeat echo. And when we repeat echo, we have to look at the MR effective for this area, as well as the left ventricular size. Anyone who has very huge LV or EF that's less than 20, probably MitraClip may be too late. I just want to enter with a case. This is a case of 78 years old female who has had previous IHD with PCI and has medical therapy that's quite optimized. Note that this is the case of before 2019. I think it was January 2019. SGLT2 was not in the optimal medical therapy, but certainly at that point of time, we have optimized her pretty well, and she shows LV ejection fractions of about 28%, and the MR is very severe with MR PROA of 0.4, and the LV is not excessively dilated with a left ventricular and systolic diameter of 45. This is the echo pictures. You can see that the MR is really quite fierce despite medical therapy, and the DE shows a central coarctations gap with mitral regurgitation that's very severe. Post-mitral clip, one clip is implanted in the A2P2 scallop, and you can see immediately the MR reduction is very substantial with only mild MR at the end of the procedure. This is the follow-up of the patient on biomarkers. Just looking at the biomarkers, immediately we have a reduction in NT-proBNP, and in a month, and at 2 years, she still had quite elevated proBNP, but she has been quite asymptomatic, and she's been doing quite well without any hospitalizations. I have the opportunity to be part of these recommendations in the APSC that's published just this year. Just suffice to say that anyone who has symptomatic severe mitral regurgitation who is already on medical therapy, we should really consider a heart team assessment and refer them for MitraClip. We as a group think that the patient should receive at least 1 month of optimized medical therapy. And that will be at least something that we have to adhere to, because MitraClip procedure is really not cheap. And at the same time, those who has proportional MR, MitraClip probably do not help very much, but medical therapy certainly will help in all patients. Lastly, just to say that this is my conclusion slide. MR proportionality is a conceptual framework. It doesn't apply in absolute numbers to individual patients because of the limitations in terms of variability in methods of measurements, as well as variability in response. In fact, in cohort patients, those who did not get device therapy, after medical therapy, there's a great reductions in the LV remodeling as well. May not be that great, about 10%, but there is individual variability that we need to think about. So all patients should be on guideline medical therapy, the 4 pillars we talk about, as well as consider them for heart team referral if they are still symptomatic despite medical therapy. With that, I thank you for your attention.
Thank you for the nice talk. This is open for discussion. Any question from the panel?
All right, thank you very much for the great talk. I have a question, how long we should wait until we do the intervention, because ICD should be implanted after 3 months of optimal medical therapy. But currently we're moving away from 3 months to longer period, let's say 6 or 1 year, because with the new drugs, they're continuous reverse remodeling. So we have seen for the PROVE-HF data that at 1 year, you have much less volume than at the baseline. And this effect really takes place for a long time. So what is, in your opinion, the right time to perform the, let's say, MitraClip in patients with severe functional MR?
Great questions, Professor Park. This is always in our, what we call the heart team discussion. The first thing is, has it been optimized? So usually we really advocate our heart failure folks who probably has had more experience in looking after this group of heart failure with reduced EF patients. They normally will tell us that, we've tried this and the patients has been fairly intolerable because of low blood pressure. So in those groups with intolerable to medical therapy, I agree that we probably need to react or need to do more aggressively. But those who are doing fine, and you follow up quite regularly, those that doing fine, then I guess it's probably what we call a natural selections, that they are going to do fine anyway. So I guess it's really a team effort with everyone the ones who look after this patient. So in our center, we normally discuss this with the imager as well as our heart failure expert. So how do we do that? We really look at morphology and the patients together. So if you have a patient who are clearly very tattered and the LV is very huge, irrespective of what you do, that's going to be poor outcome. So I think this continuous review of the case is important. I don't have a good numbers, but I think most people would agree that usually 3 months is probably a good number. But 3 months what? 3 months to the fact that you have actually titrated your therapy, not 3 months just waiting, right? So 3 months, I think the important is you must be able to up titrate your medicine without any ill outcome or side effect. Failing which that you can't reverse. Because I think when it comes to heart failure, it's not just medicine. What about anemia? Have you optimized the iron supplements? Is there anything in terms of rhythm that you can control that Dr. Yu have already spoken on earlier? So it's really an art trying to piece together when you should do a mitral clip. Yeah.
Maybe I can jump in here. Jinju, that's a great question. In our consensus grouping, this question was debated, and we're debating between recommending 1 to 3 months, but we say minimum about a month. I think the group that you're talking about, most patients can wait. The group that can't wait, they'll declare themselves to you very fast. They have recurrent admissions. They might need inotropes in those admissions. What you're fearful for is the group that really goes to stage 4. They probably will benefit more from an LVAD or heart transplant rather than secondary MR intervention. So that group is very difficult to separate out. But the group that can't wait, you can see them a mile away. Most patients can. Thanks.
Yeah, although I must say that mitral clip has been used in acute heart failure. I think it's the mitral bridge study which shows that it's feasible, but it is not something, definitely not an RCT. So I would have thought that as a heart team, we have to decide both who we should treat with a device and who we should actually treat with an advanced therapy such as LVAD. So usually we will get expert like the heart failure folks to chime in here to really, they are the ones usually who will give us their opinion on it.
Any other question? It's just a very critical question. Is there any difference in terms of the etiology of heart failure? I mean, in mitral clip, or ischemic and versus non-ischemic?
Yeah, good questions. Actually, there's no difference made in terms of ischemic versus non-ischemic from what we know. Although patients with ischemia type of patient, or rather patient on heart failure with underlying ischemia, we should do revascularizations early, because revascularizations can reverse remodel the LV and can make the MR reduce. So even though you have optimized your medical therapy, we are trying to say that after you optimize medical therapy and the patient is symptomatic, then do the echo. Because sometimes symptomatic with severe MR versus patients with optimized medical therapy, the MR could have reduced. So remember to do an echo if the patient is symptomatic.
Thank you. I think time is much late behind. It's over 2 o'clock in Taipei. We have to close the section, although I think there are so many questions to be asked. Very much thanks a lot for the nice arrangement for the section. In this section, we talked about the ARNI as the first-line medical therapy for heart failure. Also, we have the new weapons. Now, that's the SGLT2I. That's more applicable for patients, except for those with ESRD or very low eGFR. And for the third part is the device therapy with the CRT, either with ablation or not, for the permanent AF. I think Dr. Yu raised her opinion that be more conservative for the AV node ablation unless it's really necessary. And the last one is mechanical instrumentation for the mitral clip to prevent the progression of, particular for those inappropriate extra inappropriate mitral regurgitation over the heart failure itself to prevent the progression of the heart failure. Of course, before the instrumentation, you got to have optimal medical therapy and to revascularize it if there is any ischemia. Thanks a lot for everybody for your effort. Without your the participation in this section would be not that really nice. Thanks a lot and see you in the air soon.
Thank you,
Bye.
everyone. Bye.
Thank you, everyone.
Bye.
Thanks
Bye.
Bye.
for the time. Bye-bye.
Bye-bye.
Bye-bye. Thank you.
Okay.